Polycystic ovarian syndrome, or known as PCOS, is an endocrine disorder where there is an imbalance of hormones in women, which causes ovaries to become enlarged and accompanied with cysts. Such hormones such androgen and testosterone exceeds beyond normal limits in females, resulting in symptoms like abnormal hair growth, acne, amenorrhea, and obesity. As it turns out, PCOS affects 12 to 21% of females within the reproductive age, but it's unfortunate that around 70% of females remained undiagnosed due to its symptoms being heterogeneous with other disorders, making it extremely challenging to identify polycystic ovarian syndrome in women. In general, the menstrual cycle in females is highly dependent on the hormonal regulation. The follicle-stimulating hormone produced by the pituitary gland within the brain commands the production of the sac, which surrounds the egg, which forms a follicle. The luteinizing hormone, which is also produced by the pituitary gland, elevates and lowers within a short time, which signals the ovary to release an egg from the ovary into the fallopian tube, and the follicle left behind slowly disappears. This doesn't happen with polycystic ovarian syndrome. Women with polycystic ovarian syndrome, their follicles do not mature and ovulation does not occur. Because of this, the luteinizing hormone is always high during the menstrual cycle, and thus the follicle remains in the ovary and is converted into a cyst. It is this cyst that leads to hormonal imbalances, such as abnormally high testosterone and androgen levels. Females of reproductive age with polycystic ovarian syndrome is usually associated with obesity, insulin resistance, and type 2 diabetes. The menstrual cycle of women with polycystic ovarian syndrome tends to be irregular to no menstrual cycle at all. The prevalence of acne and hirsutism is the result of abnormal increase of androgen production. If a blood test were to be done, there would be a higher than normal amount of free testosterone in the blood sample, which is caused by the cysts in the ovaries. On the ultrasound, the ovaries will be presented with lobulations within the ectotasia of the ovary.
PCOS is thought to be a multifactorial disease. There are 4 main contributors. Genetics. Twin studies have shown that PCOS may be heritable and several individual genes have been linked with the condition. Intrauterine androgen exposure. Animal studies have demonstrated that exposure to higher than normal levels of androgens in utero may lead to PCOS-like traits in adulthood. There is some preliminary evidence for this in humans, but further research is warranted. Environmental factors. Sedentary lifestyle is well known to lead to obesity, which plays a significant role in PCOS. Exposure to androgen disrupting chemicals, particularly BPA, which we find in plastic drink bottles, has been associated with PCOS features such as ovarian cysts and infertility in animals, and are thought to contribute to the condition in humans, although there's still not enough evidence to prove that. Obesity. Hyperinsulinemia is known to exacerbate PCOS by inhibiting testosterone binding and encouraging production of androgens in the ovaries. Women with PCOS are likely to have subfertility due to the lack of ovulation. Following on from that, if they do get pregnant, they're likely to miscarry. This happens in early pregnancy in 30 to 50% of women with PCOS and is thought to be due to a combination of factors including insulin resistance, elevated androgens which interfere with implantation, and endometrial dysfunction. That list is not exhaustive. In women with PCOS, the ovarian cycle is not completed, so the corpus luteum does not form and therefore no progesterone is produced. This creates an unopposed estrogen environment which, combined with irregular to no menstruation, causes the endometrium to thicken. When this goes beyond a certain thickness, which is 15 millimeters, this is called endometrial hyperplasia, and if this is not treated, it may become malignant. Women with PCOS are said to be around 3 times more likely to develop endometrial carcinoma than healthy women. Obesity-related diseases are also quite common in PCOS. As we said before, obesity plays quite a significant role. These include diabetes and cardiovascular disease due to elevated cholesterol levels. Women with PCOS are also at higher risk of psychiatric conditions, including anxiety and depression. The aim of treatment in PCOS is to alleviate symptoms and lower long-term health risks. There are 3 lines of treatment. The first line is lifestyle changes, which include weight loss, exercise, and improving diet. It has been reported that as little as 5 to 10% of weight loss can correct ovulo or anovulation and therefore increase fertility. Cosmetic approaches such as shaving, waxing, and laser treatment can be used to reduce hirsutism and therefore improve quality of life for women with PCOS. The second line of treatment is pharmacological, and this includes the oral contraceptive pill for regulation of menstrual cycles and reduction of androgens, anti-androgen medications to treat hirsutism and acne, and metformin to increase insulin sensitivity so the body uses it more readily. Anti-androgens are not recommended in pregnancy as they are teratogens, which means they can cause birth defects. Other pharmacological agents used to induce ovulation are clomiphene citrate and gonadotropins such as FSH and HCG. But these are last resort measures due to increased risk of multiple gestations and ovarian cancer because of overstimulation of the ovaries. The third line of treatment are surgical approaches, and these are ovarian drilling and IVF if the woman wishes to conceive. Ovarian drilling uses cauterization or laser to create around 10 small perforations in the ovary. By decreasing thick tissue, androgen production is reduced and normal ovulation can occur.
When diagnosing PCOS, there is no single test on its own that can show that you have PCOS. A doctor will need to evaluate the symptoms and give you a physical exam along with blood tests to help you find out if PCOS is present. When formally discussing the criteria of diagnosis of PCOS, the Rotterdam Criteria Guideline is the most widely used in Europe, Asia and Australia. Based on the Rotterdam criteria, diagnosis can be made by identifying 2 of the 3 following features. Oligoanovulation, often seen in women with menstrual cycles greater than 35 days apart or with shorter cycles that occur in less than 21 days. Hyperandrogenism refers to excess androgen levels in the body. Often this excess production of androgen will show signs of unwanted hair growth in women. It can be difficult to identify as most women treat this condition themselves and is not an obvious sign during examination. The best way to test for hyperandrogenism is by obtaining a blood test to obtain the testosterone levels present in the body. Polycystic ovaries on ultrasound. An ultrasound of the pelvis is often requested. This will provide a diagnosis image of the ovaries. The sonographer will check for cysts in the ovaries and measure the thickness of the lining in the uterus. Ovaries may appear to be 1 to 3 times larger than normal. PCOS is usually identifiable when 25 or more follicles are seen in each ovary. It is also noted that it can occur in unilateral polycystic ovary, but is quite rare. Before starting younger women on hormonal therapy to regulate their menstrual cycle, it is important to know that ultrasound is not a reliable source in the diagnosis of PCOS, and before diagnosis, all other etiologies must be excluded, such as congenital adrenal hyperplasia, androgen-secreting tumours, Cushing's syndrome, thyroid dysfunction, and hyperprolactinemia. During the process of diagnosing for PCOS, a review of the patient's medical history is required and assessment of the physical symptoms is taken out, including weight measurements and BMI levels. Diagnostic imaging by using ultrasound to image the uterus, ovaries and pelvis can be requested to identify any cysts on the ovaries and whether or not one or both of the ovaries are enlarged. During the ultrasound examination, women who are sexually active may take part in a transvaginal examination to get a much closer and clearer look of the ovaries and pelvic area. MRI is not considered a warranted diagnostic investigation of PCOS, but has recently been explored and is recommended in patients in which ultrasound is inconclusive or non-diagnostic. MRI of the pelvis may show the same sonographic features demonstrated in an ultrasound examination and may be of use when transvaginal imaging cannot be performed. Blood tests. Hormonal blood tests are used to assess the levels of any excess androgen stored in the body. Blood tests such as testosterone and free androgen index are most highly regarded when diagnosing whether hyperandrogenism is detected. Other blood tests that can be useful include sex hormone binding globulin, dehydro. Oh God, I can't say that word.
It's the DHEA.
Yeah, I just said it. The use of ultrasound imaging as part of PCOS diagnosis is used to identify and document the presence of polycystic ovaries. The following documentations are needed when conducting an ultrasound of the ovaries: the ovarian volume and the number of follicles. The criteria that defines a polycystic ovary is in an ultrasound image based on the appearance of the ovary in one single imaging plane, where the ovary contains at least 10 follicles arranged peripherally around an echodense stroma. The key technical requirement of the amount of follicles is that the number of antral follicles present within the entire volume of the ovary must be counted. When PCOS is demonstrated on ultrasound, some common findings are noted. Ovaries are enlarged and rounder than normal, increased stromal echogenicity, numerous small cysts less than 5 ml that line up periphery in a string of pearls appearance. 10 or more cysts consist of 2 to 8 ml in diameter and arranged around an echodense stroma.
A pelvic scan includes both a transabdominal and transvaginal approach. When scanning for PCOS, it is recommended for a complete examination that both these techniques are done. However, the patient can refuse either if they wish. An intimate exam varies from patient to patient. It depends on factors such as age, sexuality, previous experiences, and religious or cultural reasons. Consent may be implied or written. Local workplace guidelines state the examinations where written consent is needed, and a chaperone can also be offered. Evaluation of the pelvis can be performed either transvaginally using the endocavitary transducer or transabdominally using the curvilinear array transducer. The curved array transducer has a low frequency to increase the depth and penetration of the ultrasound waves. However, the transvaginal transducer is closer to the anatomy being assessed, so has a higher frequency. The transabdominal has a curved appearance, however the transvaginal is long and skinny. You can see the differences in the images. For the transabdominal scan, the patient must have a sufficiently full bladder of approximately 100 cc or greater. This is so that the bladder can provide a sufficient window to view the anatomy. It is advised that the patient finishes drinking 1 litre of water 1 hour prior to the appointment and doesn't void during this time. The patient is asked to empty their bladder when performing a transvaginal scan. Therefore, it occurs after the transabdominal. Emptying the bladder avoids compression and displacement of the pelvic anatomy. The patient history should be asked before the pelvic ultrasound takes place. This includes previous surgery, menstrual history, previous pregnancies, medications, and any other relevant information. Changing the patient into a gown is optional. The patient is exposed from the xiphoid process to just below the pubic bone and should have cloths tucked into their clothing to avoid coming into contact with gel. The patient can be changed into a gown or remove the bottom half of their clothing with a blanket covering from their abdomen down for a transvaginal scan. Changing the patient into a gown is optional for a transabdominal scan. The patient is exposed from the xiphoid process to just below the pubic bone and should have cloths tucked into their clothing to avoid coming into contact with gel. The patient can be changed into a gown for a transvaginal scan or remove their bottom half of clothing with a blanket covering from their abdomen down. Patient history should be asked before the pelvic ultrasound takes place. This includes previous surgery, menstrual history, previous pregnancies, medications, and any other relevant information. Changing the patient into a gown is optional for a transabdominal scan. The patient is exposed from the xiphoid process to just below the pubic bone and should have cloths tucked into their clothing to avoid coming into contact with gel. The patient can be changed into a gown for a transvaginal scan or remove their bottom half of clothing with a blanket covering from their abdomen down. The patient is in a supine position when using the transabdominal technique. When using the transvaginal technique, patients are to be in a lithotomy position or can be supine with the elevation of the woman's pelvis achieved with a transvaginal sponge. The transabdominal approach allows the evaluation of the pelvic and intra-abdominal structures. The two planes in which the anatomy is surveyed are the transverse planes and the sagittal planes. The transverse plane orientations can be seen on the slide. The marker of the transducer should be orientated towards the patient's right side. The sagittal plane orientations can also be on the slide. The marker on the transducer should be orientated to the patient's head. Thank you. The transvaginal approach allows the evaluation of the pelvic structures. The two planes in which the anatomy is surveyed are the sagittal planes and the transverse planes. The sagittal plane is visualized when the probe marker points towards the ceiling. The sagittal plane orientations can be seen on the slide. The transverse plane is visualized when the probe is towards the patient's right side. The transverse planes orientations can also be seen on the slide. Here we have a protocol as an example. Each workplace will have slightly varying protocols that the sonographer must follow, but they all aim to assess and document the same structures. So, inform the patient of how to obtain results, office procedures, and ask them if they have any questions before showing them the way out. Wipe down the transabdominal transducer and patient's abdomen to remove excess gel. Instruct the patient where the toilet is and give them privacy to get changed into, I'll just do that again, sorry. Inform the patient of how to obtain results, office procedures, and ask them if they have any questions before showing them the way out. Wipe down the transabdominal transducer and patient's abdomen to remove excess gel. Instruct the patient where the toilet is and give them privacy to get changed if a gown was used. Once the transvaginal scan is complete, remove the transducer from the vagina and dispose of the protective cover. After removing the remaining gel with either a paper towel or soap and water, it must be sterilized. This process depends on your department, but a Trophon unit is most commonly used. The patient should be given privacy to remove excess gel and get changed into their clothing.